Thank you very much, Carol. Can everybody hear me okay? Yes? Okay. I'd like to start by firstly thanking you all, as Rob did, for being here today. It's really my pleasure to be able to present to you the work that my group's been doing for the past few years, looking at trying to understand sleeping cancer cells, whether or not we can wake them up, and why we might actually want to wake up a sleeping cancer cell. So starting the big picture in the clinical setting, I'm sure many of you are well aware that 1 in 8 women will suffer from breast cancer at some stage in their life. But what's less well appreciated is that 90% of the mortalities associated with breast cancer are actually due to metastasis of the original cancer to a distant site, another tissue in the body. And what's less well appreciated is that 75% of these metastases from a breast cancer actually occur in the skeleton. So really preventing bone metastases will significantly reduce mortality due to breast cancer. And really developing a better understanding of this process is key to us really preventing the mortality and that we see from patients that have metastases from breast cancer. Now, this is not just the case for breast cancer. Quite a large number of cancers, unfortunately, do target the skeleton. This is particularly so in the case of multiple myeloma, where nearly all patients will suffer from skeletal involvement, where we see these lesions throughout the skeleton. In patients that suffer from breast and prostate cancer, we also see quite high incidences, as well as these lower incidences in other cancers. But our group has had a particular interest in these cases up here in myeloma, breast and prostate because of the high prevalence of these cancers targeting bone. And of course, the issue with these cancers targeting bone are the lesions and the destruction that they cause in bone that lead to fractures and, as I'm sure you can appreciate, pain. But in addition to this, one of the other issues when a cancer does target the skeleton is that disease relapse is incredibly common. Unfortunately, when a cancer does target the skeleton, it becomes incurable, and although we can target with chemotherapy, we can achieve some remission, relapse is incredibly common. So we really need to develop our understanding of this process better so we can come in and have better outcomes for patients affected by these diseases. So what do we already know about cancers that grow in bone? We know that these cancer cells, shown here as these little purple blobs that come into the bone environment, they can survive here for really sometimes for quite a long period of time, up to maybe even 10 years before they start to grow. So they've arrived here through the circulation, they've disseminated or broken away from the original tumour like the breast or the prostate, and then they've arrived in the bone environment. They can survive here for a long time, and then something happens that switches them on to start growing. And then we see this overt tumour that grows, where these tumours take off, and they cause this skeletal destruction that we know so well when we have these overtly growing tumours. But what's really important is that we develop a better understanding of these earlier events, why the tumour cells come here and like to grow in bone, and what it is that switches them on. Because if we can really start to target these earlier events, we can prevent this happening in the first place, and that's really what we're wanting to do. So we need to really develop a better understanding of what controls this activation and waking up of these tumour cells once they get to bone to really improve treatments and survival. And that's what our research group has been focusing on. So the first question we had in regards to this is, firstly, how can we actually watch cancer cells grow inside bone over time? This is really important for us to really understand what it is that's controlling this process in the first place. So as I'm sure you're probably all well aware, this is a picture here of a bone and what it looks like, but bones they're like a tube. They have a space in the centre where the bone marrow resides, and it's in that bone marrow cavity where these tumour cells come because it's very vascular. There's lots of blood supply there. That's where the tumour cells, how they arrive in bone, and that's where they live in the bone marrow. So we've developed a microscopy technique that allows us to actually visualise and see these tumour cells inside that bone marrow cavity, so imaging through the outside of the bone into the inside of the bone, so we can actually image and see our tumour cells inside the bone. And the way that we can see these is these cells are engineered, so using genetically modified techniques, we can make these cells express GFP, which is a green fluorescent protein. So under a fluorescent microscope, these cells fluoresce green. So we can see these cells inside bone. And this image here just demonstrates to you, this is the same image just turned on its side, so you can see that the blue here is the bone. This is outside the bone. We've imaged through the bone, and we can see this green myeloma cell sitting here on the bone surface inside the bone marrow cavity. So we can actually now zone in right on one single tumour cell and see what it's doing inside bone using this technique, which is a huge advance. We haven't been able to look inside bone like this before. So now that we can see these cells inside bone, how do we start to understand what it is that's waking them up and stimulating them to grow, and how can we track cells that stay asleep, cells we call dormant, cells that haven't woken up and grown, and actually track cells that have woken up and grown, so we can start to dissect out what it is that's controlling this process. So to do this, we use what we call a membrane labeling technique. So as I mentioned, these tumour cells are green. They have this green fluorescent protein. They're always green. So these cells will always be green under our microscope. But before we inject the cells, we can label the outside of the cell with a red label. So it fluoresces red under our microscope. And so if you think about a caramel Easter egg, it's caramel on the inside, that's where the GFP is, and it's all green on the inside, and then the red is like a coating, the chocolate coating on the outside. But what happens when a cell divides is it actually shares that membrane between its daughter cells. So you see in this diagram here, it's demonstrating the cell that was completely red on the outside that then has divided, and it's shared that membrane, so that red label has been diluted as it's shared between its daughter cells, and through each cell division, the cells lose that red label. So a cell that has been switched on and woken up and growing becomes green because it loses that red label over time. But a cell that's still asleep or is dormant, it retains that red label. So we can now actually, using our microscopy technique, we can discriminate between cells that are dormant and are sleeping, have not been woken up, and cells that are growing. So this is what this looks like under the microscope, again inside the bone. In this image here, we have the bone surface. This is a three-dimensional image. So we're looking down on the bone surface here. This is outside the bone here. We're on inside the bone marrow here. You can see this group of cells here that are green only. And you can see along the bone surface here a whole lot of individual cells that are yellow. And the reason they're yellow is because they're red and green. So the red and green combined makes it yellow under our microscope. So you can see we've got a whole lot of these cells that we've injected that are still asleep, but we've had a couple of cells that have actually been activated, and they're dividing and they're growing, and they've lost that yellow or the red label, so they're no longer yellow anymore. And you can just see this turned on the side here that they're all sitting on the bone surface. So we can, using our microscopy technique, we can actually track this over time. So we can watch these cells at weekly intervals in the same spot in the same bone over intervals through the course of our model. So these images here demonstrate this at the 7 days after we've injected the cells, a week later, and then another week later. We can actually track these individual cells over time. So in the top panel here, it's the same image. I've just taken the green off so that you can see the red cells. In the bottom, you'll see here that the red cells are yellow. If that makes sense. So the green's just been taken off the image so that you can see them. So early on in our model, we can see a number of these dormant cells. Hopefully you can see this. It's projecting up where the arrows are pointing to, and also in the circle. When we put the green back on, they become yellow. We have this small colony, we call, of these growing cells that have already started growing. They've woken up. We come back a week later, and we see that this colony's growing. It's getting bigger. And a couple of these where the arrows were, these dormant cells have been woken up, and they're contributing to the growing tumour. But what's really interesting is when we come back at the end of our model, when we've got a huge amount of tumour growth happening here, on the bone surface, the bone again is just shown in blue, we can still see one dormant cell that hasn't been woken up, still asleep, and it's asleep even underneath and right next to this growing tumour. So what is it that's making this cell stay asleep and waking these cells up? And that's what we're now trying to understand. So that was our next question. What is it that drives the activation or the waking up of cancer cells to grow in bone? Now this image here is a very simple image of some of the other cells that exist in bone. It's not just the tumour cells that are in there. All our white blood cells are in there. And there's also a number of cells that play a huge role in maintaining our bone mass. And these cells we know an awful lot about because we study osteoporosis. And these are the cells that control the turnover of our bone and replacement of our bone. And it's what becomes dysregulated in the case of osteoporosis. But basically what I'm showing here is this cell here, which is the osteoclast. An osteoclast is a cell that eats away at your bone. And these are important cells that are always ongoing in your bone. Your bone actually replaces itself completely every 10 years. slows down a little as we get older and unfortunately becomes dysregulated. But the osteoclast plays a really important role in maintaining the integrity of your skeleton as it's replaced over time. So it remodels and it eats away at your bone, and then osteoblasts make new bone. But what we were wondering is whether or not osteoclasts, which as you can see here, are the main cause of the destruction that happens when we have a big tumour, and that's what causes the destruction of the bone. But earlier on in the disease process, are the osteoclasts playing a role in waking up those dormant tumour cells? So we tested this hypothesis using a drug, Rankel, which we know is something that drives the body to make more osteoclasts. So we can give this to our mice, and what it does is it makes a whole lot more of these osteoclasts that eat away at the bone. So these are high-resolution CT scans. We call them micro-CT scans of mouse bones. And we can see in the middle here how much less bone there is compared to a mouse that's not treated with this drug. And that's because we have increased the number of these osteoclasts, and hopefully you can see that down the bottom here. There's a whole lot of red cells. This is the bone marrow here. These little bits of bone, this is the cortex, the outside of the bone here. And there's a whole lot of red cells that are lining that tissue, and they're the osteoclasts. It's a stain that we use to tell us that they're osteoclasts. We've got a whole lot more of those cells just in 3 days of treatment that have led to the destruction of this bone. When we put tumour cells into this environment where we've increased the activity of these cells, we actually show that we're able to wake up these cancer cells. So in these images here on your left, this is our control mouse. As I showed you before, we have a number of these dormant tumour cells and some cells that are growing. Again, I've taken the green off the top panel. But in our Rankel-treated mice, where we've increased the activity of those osteoclasts, we've actually woken all those dormant cells up, and we don't see any of them anymore. And we've got more tumour. So this confirms to us that yes, osteoclasts are actually not only causing destruction at the end of our model, but earlier on in our model, if a tumour cell arrives into an environment or arrives on a surface of bone where there's an osteoclast that starts resorbing that bone and eating it away, it will actually wake that dormant tumour cell up. It will start growing and turn into this tumour. So this is telling us that it's not just something about the tumour cell that's keeping it asleep, it may be the environment and the place that it arrives in bone that's actually playing a huge part in this. We've also shown that the osteoblast, which is the cell that makes bone, can actually keep a tumour cell asleep. So I don't have time to show you all that data. So why would we want to wake a cancer cell up in the first place, you're probably asking? Wouldn't we prefer to keep it asleep? And you'd think that we would want to keep it asleep. However, a lot of the clinicians and a lot of people would actually like to get rid of their cancer completely. So there is one option is we could keep our cancer cells asleep if we can do that and control them that way. But one other option is to wake them up. And why would we want to wake them up? Well, that comes down to the agents we have, the chemotherapies that are used to treat cancer. Chemotherapies, not all of them, but a large number of chemotherapies, they rely on cell division and cell growth to actually work. So in an experiment we did with our model, with using this membrane label to look at the dormant tumour cells, we used an agent called melphalan. And melphalan is a chemotherapy that relies heavily on cell division and growth of cells to actually work. That's the way it works, because cancer cells do rapidly divide. That's what we all know about cancer cells. And melphalan is used quite commonly to treat multiple myeloma, and that's what this was a model of. And what we showed here, again, this is our control animal at the top here, and we see a whole lot of green cells, because that's the tumour we haven't controlled growing. But there's still a number of these red dormant tumour cells in there, like I showed you before. They can still be asleep. But when we give melphalan, and these are just 2 examples here, we can get rid of a large number, or nearly all of those green cells. The cells that are growing and dividing, we can target them and kill them. But there's just as many dormant cells there as there are in the control mouse. So those dormant cells, because they're not dividing and they're not growing, can't be targeted by these treatments. So we know these cells are resistant to chemotherapy such as melphalan that are used to treat myeloma. So although a patient goes into remission, those dormant tumour cells are still there. So what then happens when we take patients off treatment? Well, what we modelled that when we call it to model disease relapse. And this is, as I showed you earlier, we can track and look at these cells and come back to the same bone and see the same cells. And this is following 4 weeks of melphalan treatment. We can see there's a little bit of tumour here, but there's quite a few of these dormant tumour cells. We then let the mice have a period of recovery to model disease relapse, and 2 weeks later the tumour's gotten a lot bigger. But those dormant tumour cells are gone. So those dormant tumour cells that resisted treatment are now able to be woken up, whether it be by osteoclasts in the environment turning over the bone or something else. They've actually woken up. So they can contribute to disease relapse following cessation of treatment. So a waking up of a dormant cancer cell can be an issue. So this is where we're up to now with our research. We've really now developed a greater understanding of what it is that controls sleeping cancer cells and what wakes them up in bone when they arrive there. We know that only a limited number of these cells actually get activated to form these tumours, where a large number of them do stay in this dormant sleep-like state. We've shown that we can actually wake these cells up by increasing the activity of these osteoclasts. And if we can wake them up, can we then target them with chemotherapies that target those actively growing cells? And hopefully one day, which is where our research might be leading, is we'll be able to wake these cancer cells up and then ablate them with chemotherapy to really remove every tumour cell we can. Or we can do the converse, and we can now look at ways to keep these cancer cells asleep, and people can live with their sleeping cancer cells. Either way, there are options, and we're now learning so much more about this. It gives us these opportunities to really lead towards a cure for these diseases, rather than seeing the disease recurrence that's so common. So coming back to where I started with the big picture and the clinical setting, we've now improved greatly our understanding of how tumours grow in bone, and we're progressing towards a greater understanding of what controls this. And this will ultimately lead to new treatments that will reduce disease relapse and, importantly, improve survival. And this applies not only to multiple myeloma, all those cancers that I said that can target bone. We've done a lot of this work. We've done the same sorts of studies in breast and prostate cancer models as well, and see the exact same things in these diseases. So with that, just a quick thank you to a large number of people that contributed to the work that I've shown you here today. Obviously, very importantly, our funding sources, which come from government funding as well as Cancer Council, as well as private donors, and importantly also the foundation here at Garvan, who play a huge role in supporting the research of all of our researchers, as you heard earlier from Carol. They're providing the infrastructure for us to work within. So with that, I'd like to welcome some questions, hopefully. Thank you.